Today, we are all going to start with a series on fighting respiratory infections. And everyone knows that the respiratory infections are the bread and butter of our practice, particularly the pediatric practice. And every parent gets little tense and anxious when the child in the family gets cold, cough, and fever, and he immediately rushes to the pediatrician. Now, it is necessary that a pediatrician has a thorough information of respiratory diseases, and right from the nose to the lungs, all the diseases which affect the respiratory system are to be well mastered by the pediatrician, because the child may come to a pediatrician for simple runny nose. The discharge could be either watery or it could be mucopurulent. The mother might be worried about noisy breathing. The mother might be worried about breathlessness or grunting at night, so on and so forth. And that's why it is necessary to know the interpretation of the symptoms which have been told by the parents. That is number one. Many times parents also these days, they know the term viral. Recently, I had one small little child, and she came with the parents, and she had a small little doll in the hand. And while I was examining this small little girl with cough, cold, and fever, the girl herself started speaking, "Doctor, this is viral, this is viral." And she was consoling the doll, telling her that this is viral. So even small little children know that this is viral. Okay. And we should all know that viral infections are generalized. Okay. So when a child comes to you with fever, cough, cold, red eye, and along with that some rash on the body or watery diarrhea, this is most likely to be viral, because there more than one system is involved. Okay. While bacterial infections, for example, tonsillopharyngitis, where there is a follicle on the tonsil, or pneumonia, where there is a patch of pneumonia, these are localized infections and they are bacterial. Okay. Even in other systems, for example, Bacillus dysentery, when we have blood and mucus, it's only localized to the GI tract, and this is Shigella or E. coli. And that is why we should know that viral infections usually are generalized, while bacterial are localized. And the most important thing that we tell our parents, that you give paracetamol, the fever comes down, and the child is playful after the fever comes down. This is almost always viral, because in the interfebrile period, when the child is playful, when the child is eating well and sleeping well and smiling, it is almost always viral. But in the interfebrile period, when paracetamol is been given, fever has come down, but even then the child remains sick, and the mother says, "No, Dr. Jog, there is something wrong. Every day the child is really playful. He hits his younger brother and he throws objects here and there. Okay, but he is not the real self today. So you should suspect that there is something wrong. It's likely to be bacterial." So there are some points of difference between viral as well as bacterial. With all said and done, then we should know which parts of the respiratory system are affected by viruses more often, and which parts are affected by bacteria more often. Okay. And in today's discussion, we will be discussing all that, and then how to approach, how to find out whether this child is, getting better or getting serious. So with all that, we will have a brief and a crisp discussion for initial 30 to 40 minutes, followed by some concluding comments from my side, and then some questions from the audience. We have Dr. Sanjay Nathu, who is a good friend of mine, and he will give the presentation to begin with on these aspects which I just told you, and some of these points which could probably be of great help, we will revise at the end. So Sanjay, you can start sharing your screen and you can present your points, and after your presentation is over, we will summarize and then have some questions from the audience. So it's over to you now. Thank you.
Right. Thank you, Dr. Jog sir, and the organizers for giving me this opportunity to discuss the approach to respiratory infections. Just allow me to share my screen.
Yes, I can share some.
Is my screen visible?
Yes. Yes.
Okay, so today we are going to talk a little bit about the approach to common respiratory infections, especially in our pediatric practice. And as Jog sir has already mentioned, they form a big chunk of our pediatric practice, and we face these problems day in and day out while dealing with the patients and their parents. So in the next 20 to 25 minutes, we are going to discuss some common pediatric infections which we face in our practice. We all know that the pediatric infections can be a very minor or mild infections, but they can also get complicated or they can present directly in a very severe way. So there is a vast spectrum in these pediatric infections ranging from very mild to very severe. And we also should accept that they are often overdiagnosed and treated irrationally at times, giving unnecessary medicines just to satisfy the parents and sometimes even unnecessary antibiotics. So let us see some common respiratory infections which we face in our practice. We'll try to go case by case, and this is the first case. So this is a 6-year-old girl who attends daycare, and she has presented with rhinorrhea and a daytime cough since the previous 8 days. She had a fever for only the first 2 days, and the appetite has been poor. So the parents are complaining the child has not eaten anything for the last 2 days, hardly is she drinking any water. Now on examination, there is a clear rhinorrhea which is present and hardly any other finding are present in the examination. So her throat is normal, her chest is normal, so everything seems to be fairly okay. Now, we all know that this is the garden variety common cold, which we see day in and day out in our practice. And the last 3 or 4 months, I'm sure all of you must have faced a lot of such patients with episodes of common cold coming to your outpatient department. So what are the organisms which are commonly involved in the etiology of this common cold? We all agree that common colds are basically viral in etiology. Now, there are 2 types of viral pathogens which are involved. There are some pathogens which primarily cause only viral cold, and there are some which are causing some other syndromes along with symptoms of common cold. So the commonest among those which cause only basically a cold are the coronavirus and the human rhinoviruses. Sometimes these human rhinoviruses can also cause some wheezing, and sometimes they also may lead to bronchiolitis. RSV, respiratory syncytial virus, we all know is a common cause of bronchiolitis in less than 2 years of age children. But one of the commonest presentations of the RSV is a common cold. Similarly, HMPV, that is human metapneumovirus, is known to cause pneumonia as well as bronchiolitis. And in some older children, it has been shown to trigger episodes of wheezing or asthma as well. Influenza is known to cause influenza, that is a flu, as well as pneumonia and croup, but many times it can just have a presentation of a runny nose and nothing more. Similarly, parainfluenza as well as adenovirus, and adenovirus we all know is associated with symptoms which may be relatable to the eye as well in the form of conjunctivitis. So it causes something called as pharyngoconjunctival fever. Enterovirus and Coxsackie. So last 2-3 months we have seen n number of patients presenting with this infections with Coxsackie virus or enteroviruses. They may present with a typical hand-foot mouth disease or only the herpangina, but at the same time, they can also present as simple running nose and common cold. So we have to remember that last 2-3 months, several patients and their parents, especially the grandparents, have approached her how to increase the immunity of my grandchild. He's been getting colds every month or 2. And we all should know that on an average, all children tend to get about 6 to 8 episodes of common cold per year, and this is a norm seen in most of the children. In a small minority of about 10 to 20%, the number of episodes in an year may increase to almost 12 per year. So these children may get almost a monthly episode or a 3-weekly episode of common cold, and still these children are perfectly normal. It has got hardly anything to do with their immunity. As the child grows older and he has seen a lot number of viruses, the number of episodes go on decreasing with increasing age. And by the time child becomes an adolescent or adult, he hardly gets 2 to 3 illnesses per year. And these illnesses also tend to be very minor as compared to the severity of illnesses which he has faced or she has faced in the early childhood. One of the important risk factors which causes these repeated episodes of common colds, especially during the first year of life, are the daycare centers. And with the modern lifestyle, when both the parents are working and the family is a nuclear family, there is hardly any option other than to keep the children at daycare centers. Now, the daycare centers are a place where the child gets exposed to so many children coming from different backgrounds, and hence they tend to get a lot of infections in this first year of life from the daycare centers. So almost 50% more colds are seen in children who are cared at daycare center rather than those who are seen to be cared only at home. So if anyone asks how to decrease the episodes of cold, one of the factors could be the excessive exposure which is occurring in the daycare center. Typically, the common colds begin with a scratchy, sore throat, and usually they proceed to nasal obstruction and a rhinorrhea, that is a running nose. Commonly, the initial part of the syndrome has watery discharge coming through the nose. Almost 2 out of 3 children are likely to get a cough, and the cold may last for a couple of weeks. Fever and constitutional symptoms may be present in the initial part for the first day or two, and the fever usually subsides after that day, after the second or third day, but the cough and cold may persist for a longer time. Again, an important thing, typically we see a child, we try to counsel the parents and tell them that this is a viral infection and nothing needs to be done other than some symptomatic relief medicines. However, they come back at our door on the 3rd or 4th day saying that now the secretions which are coming through the nose are greenish or yellowish green, and they believe that it is a severe infection which needs antibiotics. We have to convince them or counsel them that change in color or consistency of secretions is common and has got nothing to do with the etiology of the cold. Secretions which persist for longer time may contain a lot of neutrophils, polymorphonuclear neutrophils, and the enzymes from these cells can cause the colors of the secretions to become greenish or yellowish green. This does not indicate sinusitis or bacterial infection by itself. If you examine the child, he or she may have swollen erythematous nasal terminates, but this is not again a consistent finding which is going to be very important. So how do you treat? Treatment is basically supportive. At the outset, when you see the child for the first time, when the child presents to you with the fever and cough cold for one day, that is the right time to guide the parents that it is very likely the fever will go away after a couple of days or 3 days, and the cough and cold may persist for a longer time. So this is what we call as anticipatory guidance, and this would present further visits of the parents coming back to you again and again for the same complaint in that particular episode. We also need to be convinced ourselves, of course, and then only we can convince the parents that antibacterial therapy is of hardly any use in the treatment of common cold, and there is no role of antibiotics in treating common cold. What is important is maintaining a good hydration, and in the first 2-3 days, the intake of the child is going to be low. So more of liquids, especially warm liquids, are going to be helpful for the child. A younger child needs to be continued as far as breastfeeding is concerned, and we can ask them to take precaution by hydrating the child by giving various types of fluids like plain water or ORS or lemonades or warm soups and something of that sort. Simple saline instillations or saline irrigation does have a role in clearing of the nasal mucosa, nasal cavity, and does help in symptomatic relief to some extent. However, one should remember that non-prescription cough and cold products are not to be used for infants and children, especially those younger than 6 years of age. Now, it has been shown by research that first-generation antihistamines may reduce rhinorrhea by 25 to 30%. So that is one of the prominent complaints which is troubling the child. Sometimes, occasionally, first-generation antihistamines may help. And here we have to remember that the next generation antihistamines may not be useful because this activity of decreasing the rhinorrhea is basically due to the anticholinergic effects of the antihistamines, which are seen more prominently in the first generation and not so much in the second and the further generations. Systemic decongestants in the form of pseudoephedrine may be helpful to some extent to decrease the nasal congestion. As compared to phenylephrine, pseudoephedrine is slightly better, and oral adrenergic agents in general are less effective than topical preparations for nasal obstruction. So sometimes you may need to prescribe xylometazoline or oxymetazoline rarely, especially to ensure that the child is able to sleep peacefully for at least some part of the night. Popular medicines like vitamin C, guaifenesin, and inhalation of warm humidifier air. So this is again a very common inquiry with the parents. Shall we give steam to the child? So it has been shown that steam or vitamin C are only as effective as placebo for the treatment of common cold. In fact, one should remember that with small children who are very active, this steam, the source of steam, that is a hot water, may be more of a trouble because it may get spilled and cause more trouble to the child. So there's hardly any advantage of giving warm humidified air or vitamin C like medicines. This is the typical graph of an uncomplicated viral urinary tract infection. So as can be seen, the severity of the fever is high in the first 2 days, but usually after 2 or 3 days, the fever disappears. However, the respiratory symptoms gradually increase for the first, third and fourth day, till the third and fourth day, but they keep on lingering till almost a couple of weeks, and that is normal. So you need to just counsel the parents that only supportive treatment is all that is required and no medicines need to be given for a prolonged period. Now, this case which we saw has progressed, and after the adequate counseling, the child has improved for a week or so. But however, now the child has again developed high-grade fever, and now this time there is thick mucopurulent discharge from the nose. So the child had improved, the fever had disappeared, the cough and cold seemed to be improving, but again there is worsening with increase in fever, and now the discharge is thick and mucopurulent. So we have to consider in such situation the likely possibility of acute bacterial rhinosinusitis. When do you consider the possibility of rhinosinusitis? So in situations where the symptoms have been persistent for a long time, or they have been severe, or they have worsened over time, that is a time when we consider the possibility of acute bacterial rhinosinusitis. So a nasal congestion or rhinorrhea or cough more than 10 days without improvement. So remember, in a typical viral respiratory infection, the nasal and symptoms and the cough tend to improve, though they may persist for 10 or 12 days. Similarly, a temperature more than 38.5 degrees Celsius for more than 3 to 4 days with a purulent rhinorrhea for more than 3 to 4 days again may point towards bacterial infections, as well as return of symptoms after initial resolution or new or recurrent fever, increase in rhinorrhea or increase in cough should warn us that the child may have progressed to an acute bacterial sinusitis. Now, what are the common infective agents or the etiological agents which are involved in sinusitis? So I'm sure all of you are aware that the bacteria which are involved are Streptococcus pneumoniae, which is the commonest, H. influenzae or Haemophilus influenzae non-typeable, and the third one, which we often tend to forget, is Moraxella catarrhalis. So these are the common bacteria which tend to cause sinusitis. The treatment of choice in such situations is amoxicillin at 40 mg per kg per day in 2 divided doses. But you have to remember that the treatment needs to be continued for around 14 days, that is 2 weeks. Many times you may require to give amoxiclav combination if there is no adequate response to amoxicillin. And again, the treatment is continued for 14 days. The other alternatives which may be thought of are cefpodoxime at 10 mg per kg per day, cefuroxime at 30 mg per kg per day, or cefdinir at 14 mg per kg per day. Again, the rate of recovery is good for all of these agents, but the duration of treatment is 14 days, that is 2 weeks. Coming to our next case. Now, this is again a 6-year-old boy, but he has developed sudden onset fever, throat pain, and vomiting. If you examine this child, you have found that there are swollen red tonsils and tender jugular-digastric lymph nodes. So what is the likely diagnosis? You'll all agree that this looks like an acute tonsillopharyngitis, and this is something of an image of that child, where you can see the white patches with the congested tonsillar pillars and white patches on the tonsils. So this is the classical acute tonsillopharyngitis, and the commonest organism we all know is Streptococcus pyogenes. Now, is there any way to differentiate the viral etiology and the bacterial etiology? Because all said and done, the common cause of pharyngitis still remains viral as compared to the bacterial. So, as Jog sir has already pointed out in his introductory remarks, there tends to be generalized symptoms when there is a viral infection. So the child may have a diarrhea, the child may have eye discharge, conjunctivitis, coryza, cough, hoarseness of voice. There may be stomatitis, and there may be a viral exanthem as well. So systemic presentation could be more likely in a viral, while in a bacterial or a Streptococcus pyogenes type of infection, there is a sudden onset of sore throat. Older age group, 5 to 15 years is involved. Fever is quite high grade, interfebrile period also the child tends to be dull and ill. There may be headache, some nausea, vomiting, abdominal pain. Of course, classical tonsillopharyngeal inflammation with patchy tonsillopharyngeal exudates. Palatal petechiae are classically seen in this bacterial type of pharyngotonsillitis. And tender lymph nodes, typically the jugulodigastric lymph nodes tend to be tender, enlarged. Sometimes you also may get a scarlatiniform rash. All said and done, these clinical features may not be always visible or decipherable. So there have been scoring systems which have been developed to help us, to aid us in deciding whether it's a bacterial infection or a viral infection. And one of them is the Mackissack decision rules. Here, various parameters have been given marks if temperature is more than 38 degrees Celsius, or there is no cough, or there is tender anterior cervical lymphadenopathy and tonsillar swelling or exudate. All these contain 1 mark, are given 1 mark each. An age group of 3 to 14 years is given 1 mark, while as age of 15 to 44 has no marks, and more than 45 years minus 1 mark. The idea is that the older the patient, less likely it is going to be a bacterial infection. So what do you do with this scoring? You of course add the scores. If the score is 0, then the chances of Strep pyogenes being the causative agent is almost very low. The score, if it is 3 or 4, especially if it is 4, only then you are more in favor of having a Streptococcus pyogenes infection causing the tonsillitis. So these decision-making rules help us to decide whether we need to start antibiotics or only symptomatic relief is sufficient. Again, the antibiotic of choice remains amoxicillin at 40 mg per kg per day. Important thing to remember, it can be given once daily or in 2 divided doses. The duration of treatment ideally should be 10 days. An alternative could be a cefalexin, which is given orally at 40 mg per kg per day, or a cefotraxone 30 mg per kg per day. Azithromycin can be given if there is a type 1 allergy to the penicillins at 10 to 12 mg per kg per day once daily for 5 days only. However, azithromycin has recently shown a lot of evidence of resistance, and so it is no longer the preferred drug. A couple of images just for your information. Now, what is this? The child seems to have some ulcerative lesions at the corner of the mouth, as well as in the palate there seem to be ulcers, and is also having a sore throat and high fever. Similarly, this child has multiple small ulcerative lesions on his soft palate, on his palate and throat. So the first one is an image of herpetic gingival stomatitis, while the second is the herpangina, which we have been seeing in the last couple of months. Important thing to remember, though the child may look ill with a drooling of saliva because of difficulty of swallowing, because of these painful lesions, we have to remember that ulcers in the throat are basically viral in origin and do not require any antibiotic. Coming to the next case. Now this is a child, Y, who with 3 years of 3 years of age, he visits the ER at an odd time of 2 a.m. The history of sudden onset of breathing difficulty, which has been preceded by history of mild cold and fever. There have also been family members who are suffering from a little bit of cold, and on examination, this child is restless but comforted by parents. There is an audible stridor, which is worsened when the child becomes irritable or starts crying. There is some amount of intercostal retractions as well, and on examination, the child has a tachycardia of 120 beats per minute, and a respiratory rate which does not show any tachypnea. The oxygen saturation of the child, however, is slightly low. It is around 82%. So the diagnosis in this case with a breathing difficulty with stridor and a typical cough is croup. So now croup is also known as laryngotracheobronchitis, and it's a common respiratory illness, most commonly due to a viral infection. The characteristic features of croup are barking cough, inspiratory stridor, hoarseness of voice, and respiratory distress. So this barking cough is very classical, as classically seen in children with croup. Similarly, stridor is a very common and prominent feature of croup-like illnesses. Etiology again is predominantly viral. Parainfluenza is the most common virus. Type 1, type 2, and type 3 account for almost 75% cases of croup. Influenza A and B may also be responsible. And similarly, adenovirus, respiratory syncytial virus, and sometimes even the measles virus can give rise to a viral croup. Bacterial agents like diphtheria and mycoplasma may sometimes be responsible, for this croup-like illness. The severity of the croup can be graded on the basis of presence of and the severity of stridor, chest retractions, cyanosis, the heart rate, whether there is tachycardia or not, whether there is respiratory distress or tachypnea, as well as the mental state of the child, and it's classified as mild, moderate, and severe. Investigations are usually not required. Croup is a clinical diagnosis based on the symptoms and the typical stridor and the barking cough. Rarely, you may need to do investigations, especially if there is a worsening of the croup or the child is not responding to routine symptoms or you're suspecting something else, for example, a foreign body or something of that sort. And in such situations, then X-ray of the neck will show the typical characteristic steeple sign or the steepling, that is narrowing of the airway. Treatment is basically a lot of supportive treatment. A comfortable position is to be given to the child. The baby needs to be observed for some time in the emergency room, and steroids, if not given before, they should be given. Oral or intramuscular steroids have a very dramatic effect, and the croupy symptoms typically disappear within hours. Even nebulized steroids may have some role. Repeated dose of nebulized steroids can be given if the previous dose has been given for more than 12 hours after the first dose. If there are worsening symptoms or if it is a severe type of croup, then there may be a role of nebulized adrenaline. This may be repeated as indicated. And if the child is asymptomatic after some time, then the child may be discharged with parental advice. So this croup is usually a very common viral illness which responds very well to steroids. So steroids, you can give nebulized budesonide 2 mg around 12th hourly, or oral or IM dexamethasone 0.15 to 0.3 mg per kg. Even oral prednisolone may be given 1 to 2 mg per kg. Adrenaline, if it is used for nebulization, the dose is 0.5 ml per kg of 1:1000 dilution. A maximum of 5 ml can be given. Here we come to our next case, which is now a 7-month baby boy brought with complaints of increased respiratory movements and difficulty of feeding since only last one day. The child started to have runny nose and fever for 1 to 2 days, and which has progressed to this increased respiratory distress and feeding difficulties. Clinically, the child has tachypnea, retractions, subcostal retractions, as well as some suprasternal retractions, and on auscultation, the child has extensive wheezing on both sides. This is the typical patient of bronchiolitis, which we have started seeing in the last few days since the onset of the winter. And this is a common season when we see a lot of such patients. So this is a pulmonary infection of young children, classically less than 1 year of age, which is characterized by wheezing. Commonly starts as a cough coryza, but progresses to respiratory distress in 2 to 5 days. Fever is common in the first few days, and tachypnea is a characteristic finding seen in these patients. If you auscultate, then wheeze is again very common, and expiration tends to be a little prolonged. The important thing is that we need to watch out for apnea, because of this increased respiratory movements and work of breathing, the child may go into fatigue and end up in apnea. Similarly, because of the child is ill, the intake is often poor, and the child tends to refuse the feed and may become dehydrated. Respiratory failure is again a dreaded complication, though not very common, can be seen in some patients of bronchiolitis. Positive organisms, respiratory syncytial virus accounts for almost 80% of these cases. Human metapneumovirus, rhinovirus, adenovirus, influenza, parainfluenza are the other viral etiologies which are known to cause bronchiolitis. One must remember particularly the adenovirus because it tends to be followed by a severe sequelae in the form of obliterative bronchiolitis. Management, you need to admit the patient only if there is hypoxia in the form of saturations less than 91 to 93%. If you have done an ABG, then a partial pressure of oxygen of less than 70 millimeters of mercury in room air is an indication for admission. Or if there are underlying cardiac or pulmonary diseases, then these are high-risk factors which definitely justify an admission. Treatment begins with oxygen, obviously, along with nebulized bronchodilators. And you have to remember that not all patients respond to nebulized bronchodilators. So if you are getting a response to nebulized bronchodilators, they can be continued. However, they are not essential. Supportive treatment in the form of hydration is very important. There may be some role of hypertonic solution, saline solution in treating some of these patients. Similarly, some people have tried nebulized adrenaline, which may also help in the resolution of symptoms in these patients. Rarely, these patients progress further and may land up with complications in the form of respiratory failure, which may require rarely ventilation. Here we come to one of our last cases, and here a 5-year-old apparently well-looking child has presented with wet cough for 5 weeks. So prolonged cough has been there, and the parents are consistently saying that there is a wet cough. Fever has hardly been there. The patient is otherwise fairly normal. Cough increases with some change in posture or even after just lying in bed, and also in early morning, it increases in the morning as well as on running. Some doctor has tried a short-acting beta agonist thinking in terms of asthma. However, the child has not shown any improvement with short-acting beta agonist, and there is no history of family history of asthma or atopy. When you examine this child, there is no wheezing. However, there is a rattly sound and few creps may be present bilaterally. So what is this etiology? So the likely etiology is the new kid on the block, relatively new kid on the block, which has been described, which is called as persistent bacterial bronchitis. And the treatment of choice in such situations is a co-amoxiclav at a dose of 40 mg per kg for at least 2 weeks. And this will take care of the persistent bacterial bronchitis, and the child will be back to normal with the absence of any symptoms. So this is a new entity which not many of us diagnose, but we should be aware of, and that is persistent bacterial bronchitis. I have not covered some important respiratory infections like otitis media or pneumonias because they are going to be covered in subsequent lectures in this series. So I think these are the 4 or 5 entities which I wanted to cover. Most important being the common cold, which we are seeing in the last 3-4 months, as well as bronchiolitis, which we are seeing now in the last few days. So with this, I'd like to end my short presentation. I hand it over back to Pramod Jog, sir.
Thank you, Sanjay, for this crisp coverage of the entire topic. And I am sure that our listeners have benefited a lot from your discussion. I would just like to sum up and add some points from my side. And these are all related to the presentation that you made. So listeners can remember that organisms like the viruses and the bacteria, they attack the respiratory system. And you have to remember that the nose, when it is affected usually by viruses, like the ones that Sanjay told us, like rhinovirus and the adenovirus and the influenza and the parainfluenza viruses, usually there is a watery discharge. Okay, so almost all nose involvements are viral. Tonsillopharyngitis is also, to a great extent, 70% cases is viral. And those 30% cases where it is not viral, they are bacterial. And as we all know, those bacteria are the group A beta hemolytic streptococci, which are very, very sensitive to penicillin or the beta-lactam group. Okay. And sinusitis and otitis media, which are a part of the upper respiratory system, again, they are predominantly bacterial. Okay. And the organisms, the terrible trio that Sanjay mentioned, that is the Streptococcus pneumoniae, Haemophilus influenzae type B, and the Moraxella, they attack the sinuses as well as the middle ear. So this microbiology is of extreme importance because you are not going to treat rhinitis, that is simple watery nose, because you know that it's viral. Okay. You are also not going to treat tonsillopharyngitis simply by looking at the throat and thinking that it is red, chalo amoxicillin denge, amoxiclav denge. No, that is because 70% tonsillopharyngitis are viral. Only the criteria which we just saw in the form of the scoring system, that the child is toxic, the child has a tender node, he doesn't have cough, but he has high fever, he has a tender node, and he has a follicle on the tonsil, then only you are justified in giving antibiotics empirically. And we are fortunate to have amoxicillin in the dose of 40 mg per kg useful in those cases of tonsillopharyngitis. While we know that sinusitis and otitis are predominantly bacterial. And in addition to the first line therapy of sinusitis with amoxicillin, many times as a second line therapy, we need amoxiclav also. Same is true for otitis media. Remember that many times we are confused, and parents also ask, sir, every time my child is getting cold, Sometimes he has fever, sometimes he doesn't have fever. So how to differentiate that this is viral common cold or whether it is allergic rhinitis? Of course, remember, viral infections no doubt will be self-limiting within 7 days, while allergic rhinitis will persist for about 10 days. Fever will be there in viral infections like common cold. Fever won't be there in allergic rhinitis. And then the nasal mucosa will be red if it is viral infection. It will be pale in case of allergic rhinitis. And response to antihistamines will be very good in case of allergic rhinitis. And many times this plain simple rhinitis progresses into rhinosinusitis. And the child starts getting mucopurulent discharge. The child starts getting discharge when he lies down. There is something which we earlier used to call post-nasal drip. And because it is purulent, the people who are in front of this child, they get a very, very bad odor, which is called as, halitosis. Okay. And our teacher used to tell us that, the person who has sinusitis, rhinosinusitis, he himself doesn't smell, but others smell him bad. Okay. So this is typical sinusitis. And they are the ones where, of course, the onset could be acute or subacute. Sometimes sinusitis can continue to be, for a long time and so on and so forth. So this microbiology upper respiratory system is very important. As we just saw that the viruses like respiratory syncytial virus, that will produce bronchiolitis and bronchospasm. Now we had our friend influenza recently. We had H1N1, H3N2 and all the type B influenza viruses. Now, how to differentiate this common rhinovirus from flu? Very important that a flu child will have myalgia. The flu child will have headache. The parents will say that this child is so weak that we have to really get him to the clinic. Even an older child, people, they have to bring him on the shoulders. Okay. So weakness is an important part. And influenza is a systemic disease. And that's why it attacks so many organs. COVID, which we witnessed for the last 2.5 years, and still going on in some parts of the world. How to differentiate this common cold and the flu and COVID? COVID, my dear friends, remember, we always had cough more than cold. Okay, so the throat involvement in COVID is more. Some adults had loss of sense of taste and smell. We had associated symptoms in children like diarrhea and vomiting. And there was, of course, family history of COVID. So it is important that you know the epidemiology at that particular moment. As Sanjay told us that bronchiolitis cases have started showing up. These are all typical cases which come to us. And recently we had one child who came in the early morning and with breathlessness and wheezing. And of course, we have to be very, very alert. The resident doctor thought that it's bronchiolitis and he admitted the child and started on oxygen and IV fluids. And during the rounds, we could distinctly hear a systolic murmur, and this child was of VSD, ventricular septal defect failure. So we were deceived. So remember, once in a while you may get deceived. Another child I remember long back came similarly in the early morning with breathlessness and some chest signs, and later on we found that he had a foreign body in the chest. And in the hurry of examination, nobody found that the findings were only unilateral and not bilateral. So we have to be very, very careful when we examine any child with respiratory system. Then we have seen about the noisy breathing and croup, which Sanjay very properly said that is a condition where there is barking cough, change of voice and stridor. Remember, croup, though it's majority viral, we have seen cases of diphtheria. Just 4 days back in the hospital, we had a child with diphtheria, laryngeal diphtheria coming with croup. And once in a while you may be deceived. So throat examination is extremely important. However, in a child, which we always say has epiglottitis, we have to be very careful. Fortunately, in our country, epiglottitis is very, very uncommon. It is because of H. influenzae, and the glottis, as you know, gets covered by epiglottis. These chaps, when they swallow, they get severe pain because the epiglottis tends to close the glottic opening. And that's why this is what is called as odynophagia, that is painful swallowing, is a feature of epiglottitis. The child is drooling because he cannot swallow the saliva. The child is toxic, but that's a different story. So whenever a child comes with noisy breathing, you have to be very, very, very careful. And very close to this noisy breathing is our whooping cough. And there you have this Bordetella pertussis, which always produces a cough which is very, very typical, which is called as whoop, and most of our colleagues know about it. Fortunately, because of the good coverage with this DPT vaccine, the incidence of all these diseases like diphtheria and pertussis is going down. But remember, they require boosters because the protection offered by diphtheria and the pertussis components of DPT vaccine is not great. It is only to the tune of 60 to 70%. So the immunity obtained by the vaccines given in the first and the second year wanes by the age of 5 years. That's why we give second booster at 5 years. By the time the child becomes 10-year-old, the immunity further wanes, and by 10 years they again require a booster of diphtheria and pertussis. The point is that diphtheria and pertussis, they linger on, and there have been studies from Karnataka where there have been articles written by our colleagues saying that diphtheria is down but not out. Diphtheria still continues, and we have to be very, very careful when we examine such children. And obviously, this particular child which Sanjay mentioned about bronchiolitis, and of course we are going to discuss pneumonia in one separate lecture, but then whenever mother comes and tells you that my child has cough and fever, always remember to ask which is the predominant symptom. Okay, so if mother says that, sir, the child is coughing all throughout the night, I ask Benji, what is the range of fever? How high is the fever? She says, sir, bukhar itna nahi hai, temperature is not that much. You should remember that bad cough with mild fever is airway disease, and the large airways, particularly the bronchi and the trachea, they are involved. Okay, sometimes they will come with mild fever with a wheezing sound. Again, you have to suspect bronchiolitis. And when she comes and tells you, sir, very high fever and cough, how high is the fever? Sir, इतना बुखार है, रात भर पट्टियां रखी, पैरास्टामोल दिया, ये किया, वो किया, खांसी कितनी है? खांसी इतनी नहीं है, sir. Okay, so when she says that खांसी इतनी नहीं है, but bukhar is high, it means that the child has low respiratory infection, and always ask for grunting, you know. So in Hindi they say karahana, you know, grunting. So that is the sound which the child will produce at night, and that indicates low respiratory infection. And that's why we have to be very, very clear about this entire microbiology. Which are the conditions where you should not use antibiotics? Runny nose, you know, I call them as shake hand situation. Your hands must shake when you write antibiotic for a child with common cold. In fact, I'm happy when mother says that onset is with cold, because I know that antibiotics are not required. But a child who is toxic with a tender node needs amoxicillin, you know, because we suspect that it's a streptococcal pharyngotonsillitis. All in all, we must also remember that COVID has given a gift in the form of a mask, and that's why all these respiratory infections were at a lower degree during last 2 to 3 years. But unfortunately, now people here, they are so complacent that masks are now not seen in majority of the cases, and respiratory infections would again, you know, probably increase, and we will be heading for a trouble in case if something unfortunately goes wrong. Secondly, breastfeeding. Remember, breast milk protects the child against pneumonias and otitis and respiratory infections in general. So breastfeeding is extremely important. Pneumococcal vaccine, Sanjay mentioned about children going to the daycares, and particularly those who are prematures and those who are low birth weights and those who go to the daycare centers, they need to be protected against pneumococcus, because these are the organisms which give a lot of trouble to these weaker children. Okay, and remember that all the precautions to be taken by everyone in the family, because children go to the daycare, other children come to the daycare, and child comes back to the house, and there is another child in the house. So everyone in the family, if he follows the precautions, parents, they come back from the office, again they have to see that they clean themselves properly, they use a mask before they handle the younger ones, they again take proper care, and these all precautionary measures will go a long way in prevention of respiratory infections. So my dear friends, all in all, remember that from the nose to the lungs, we have to be very, very aware of the microbiology, the areas where you need to use antibiotics, where you need not use antibiotics, how to know that the child is serious, and then how to manage these children. So with this, in case if there are any questions on the chat box, I will be more than happy to discuss them out over here. And Dr. Surekha, do you have any question at your end from the drop box which we can cover? I can see one question which says about this comorbidities. Yeah, actually, it's a question which would be probably relevant more to the discussion on allergies. But then we can just remember that whenever a child is brought for allergic rhinitis, Many times there are comorbids in the form of sinusitis or adenoiditis or otitis or associated asthma, and we have to be careful. But then when you evaluate a child with allergic rhinitis, at the same time you please see that you look out for the total ear, nose and throat evaluation, because we all know that uncontrolled asthma, many times 80% of asthmatics have associated allergic rhinitis. Of course, it's not a discussion today, but then you have to remember that many times we need to treat allergic rhinitis which is associated. And Sanjay has already told us about the use of antihistamines, and there is some comment required by one of our colleagues, Dr. Abhishek. He wants to know as to some idea about the cough lozenges. Sanjay, would you like to take up this?
Yeah, sure. So in the cough, which is commonly present with the common cold, which tends to be a little dry and irritating, lozenges are shown to have a good effect actually, and they may give some symptomatic relief to the parents mainly, because they are troubled with the continuous cough which the child is having. So cough suppressant, as we all know, are not to be used in younger children, while as lozenges in the form of, say, crystals, sugar crystals, or some commercially available lozenges, you can give small pieces for the child to chew, and the salivation which occurs because of that gives a soothing sensation to the child and may decrease the cough to some extent. Similarly, honey with a little bit of maybe a drop or two of lime juice has been shown to have a very good effect as far as the relief of cough is concerned. So yes, lozenges do have a role to some extent for symptomatic relief of cough.
And there is one of our colleagues who wants to know as to how to have relief from continuous cough without any findings.
So again, if it is a child who is having a continuous cough because of an upper respiratory infection, we have to counsel the parents that this is a viral infection and the cough may last for a few days. But as we already said, warm water, lozenges, honey and lime may help to some extent in relief of symptoms, and is a matter of a day or two and the symptoms start decreasing. However, if it is a continuous cough, you just need to be sure that you are not missing any findings in the lower respiratory tract itself. For example, there may be some amount of bronchospasm which may be associated, because we saw the viral infections. A lot of them also cause wheezing, a lot of them also cause bronchiolitis. So you should not be missing these symptoms, because if there is some amount of bronchospasm, a bronchodilator can give a good amount of relief to children with this cough.
Yeah, you're right. And then, of course, when we get a child with cough and cold, many times you find, a 5-year-old child comes to us and the mother says that he has recurrent throat infections. Okay. And then mother says that he's missing the school almost every alternate week. And they move on from Dr. Jog to Dr. Sanjay Nathu to XYZ, and all during the year, they continue to do the shopping to different pediatricians, and they also go to the ENT surgeons. Okay. And then the, child receives almost 7 or 8 antibiotic courses all throughout the year. And the ENT surgeon advises tonsillectomy, and all this goes on in the community. And they are now seeking a second opinion for you. It is extremely important that you counsel these parents properly. Tell them that these are back-to-back viral infections. When the child goes to the daycare, when the child goes to the school, he brings the infection back and again gets infected. And under the age of 5 or 6 years, many times we find that the size of the tonsils is many times, the appearance is large. Okay. It doesn't mean that there is, huge tonsil, which is pathological. So you have to counsel parents properly. And of course, with due regards to our ENT surgeons, because I always say that ENT surgeons exist because tonsils exist, and surgeons exist because appendix exists. The lighter part apart, we should always counsel properly and tell them that these are viral infections, and please get the proper ENT evaluation done. Okay. In addition to the treatment counseling, please see that they do not have deviated nasal septum, they do not have enlarged adenoids. Okay. And their sinuses are normal. There is no history of smoking. Many times, the father is a smoker, and then, the child gets cough because of the passive smoking. So many problems are there, and we will be discussing all these problems in this particular series, whenever the topic arises. But I personally feel that whenever a child is brought for recurrent sore throat, please remember that do not give antibiotics at each and every episode of this recurrent sore throat, because almost always it is a viral infection, and we always know that there is something called as a back-to-back viral infection. Okay, and one of our colleagues wants to know as to what is more effective, whether it's a dry suspension or a dispersible tablet of say amoxicillin or amoxiclav in children below the age of 2 years. So Sanjay, do you have any remark on this?
The only comment I would like to make is for the amoxiclav especially, the storage is a little tricky. It needs to be maintained at a proper temperature after reconstitution. So maybe the dispersible tablets may be a little bit preferable, because there's no question of storage as far as the dispersible tablets are concerned. But otherwise, it is, if given a choice, it is up to the parents, which the child accepts very easily, and that preparation can be used.
Yeah, you're right. And many times, of course, one of our senior teachers, Dr. Ajay Joshi, when we used to have meetings at his place alternate fortnight, alternate week, there was always a discussion on this topic. And dispersible tablets, many times he used to say that if I get a 250 mg tablet of say amoxicillin, he always used to tell the patients to break it into half. Of course, that was for economic reasons, because he always thought that a tablet which is of a higher strength can be broken and the cost would be lesser. Okay, the problem about storage is very common, because every patient who is prescribed amoxicillin or amoxiclav, we have to tell him that preserve this particular medicine in the refrigerator. Okay, and many of them bring those bottles back after 5 days with the entire solution being yellow or dark brown, and then we have to say that this is to be thrown again. He has to spend 100 rupees and bring a new one, and so on and so forth. So I personally, if you ask me, if everything goes well, dispersible tablets are really good, provided parents prepare properly. And if dispersible tablets are used, they would save some money also. Okay, of course, if someone asks as to whether it's a suspension with this water for dilution and dispersible tablet, many times, as Sanjay said, it's a personal choice. But then as regards the preservation as well as the cost, one has to look at the parents' educational level and then probably take the decision. Many poor people who come from the slums or poor sectors, they do not have refrigerator in the house, and then I have to tell them to go to the grocer shop and keep it at his place and take it out in the morning and evening and give it to the child, and then it becomes a big tough job for them to give amoxiclav or amoxicillin to these children. Anyway, good that one of our colleagues has brought out this question. We will definitely discuss this when we discuss about amoxiclav, maybe in the third or the fourth or the fifth lecture series in this particular series. Okay, I think most of the questions have been covered, and particularly all the discussion about the respiratory infections, most of the points we have covered, though we have kept otitis media and pneumonias and disorders like bronchiectasis and others little pending for the latter part. But then Dr. Surekha, in case if you have any anything to add, you please add. Otherwise, maybe you can give your concluding comments.
I think thank you so much, sir, for